So we need to start with anatomy of the upper extremity specifically. And so now we're on page 143. So hand and wrist, hand and fingers, we're going to start with identifying each one of the digits and each subsection of the digits. And we're also going to talk about the joints, the specific joints. Before I do this, I want to try to simplify this a little bit for you, because you're going to have a lot of different things to focus on. And actually, I'm not going to have you switch pages or anything. So from this point forward, for the rest of the semester, what you need to think of as far as central ray location and collimation is collimation should always be to the skin line, no larger than that. I mean, your bone's never going to stick out further than the skin line, right? So skin line, maybe a ½ inch beyond skin line. And the purpose for the ½ inch beyond the skin line, larger than skin line, is because your collimators can be off. They can misrepresent the radiation field. So if you collimate to the skin line, let's say you're doing an individual finger, how much soft tissue do you have past your bone on your fingers? Not much, not much. I mean, your finger's only, an inch wide, so if your collimators are off by ½ inch, and you collimate all the way down to the skin level, you got a problem, right? You're gonna miss anatomy. You're gonna have to go back and reshoot it. So your collimation is gonna be to about a ½ inch from the skin line at the largest. And then you need to center your central ray to the middle of the anatomy that you're interested in shooting. So that's two things. The third thing is that you need to include adjacent anatomy. All right, so you can't say that I saw the entire finger, if your collimation goes to there, right? You can't even say I saw all the anatomy if your collimation goes to the joint space. So you have to see the distal portion of the adjacent anatomy in order to make sure that you included everything that you needed to see. So three things that you really don't have to spend a whole lot of time looking at in your Merrills and in your positioning is one, central ray location. It's going to be to the center of the anatomy that you're interested in seeing. Then you just got to identify where the center of the anatomy is, right? So that's number one. Number two is collimation is going to be to, ½ inch beyond the skin lines. That's number two. Don't have to look at that. Number three is structures included, not necessarily structures shown, but structures included should be like in the hand, which is what we're looking at here. What do you suppose you want to see?
Phalanges.
All of the phalanges. So to the distal portion of each phalange, you got to see all that. And the hand is a little bit unique in that when we do a hand, we're going to want to be able to see not just the bones of the hand proper, but we're going to want to see all the wrist bones. So we have to include the distal portion of the radius and ulna. So your collimation should be open up enough so that you can see beyond the bones or beyond the skin line by about a ½ inch. And the structure shown included on the anatomy is all the anatomy that you should need the exam for this example, hand and the wrist bones, but you also need to include about a third of the radius and ulna, or at least a distal end of the radius and ulna. A third of the radius and ulna is really for the wrist bones specifically, but you need to see the distal radius and ulna. Okay, so now it's just a matter of identifying what constitutes the middle of the anatomy. And sometimes it's pretty specific. So looking at that, what would be pretty much right in the middle of that diagram? Yeah, so third finger. This here is actually a part of the hand. This forms the palm of the hand. These are what we refer to as our carpal bones. I'm sorry, these are carpal bones. These are metacarpal bones. That's the third one. That's one right in the middle. You got 5 of them. And sometimes personally, I've never seen a patient with what we refer to as polydactyl, but you may see somebody that has more or fewer fingers, born with more or fewer fingers than normal, so to speak. Okay, so that would be third. You got 1, 2, 3, 4, right in the middle, you got number 3. So you got the third. This is the metacarpal, that's a phalange, so that's metacarpal phalangeal joint, third metacarpal phalangeal joint. So sometimes it's real specific, like that, you know, and you got to know all these little portions of the bones and the joints and all that kind of stuff. Most of the time it's not. So let's say that what we want to see is our wrist bones. All right, so we're going to do a different exam for hand and wrist. So where are you supposed we're going to center for the wrist bones? To the wrist bones, right? To the carpal bones. So we're doing a forearm. So it's in the middle of the wrist bones. We're doing a forearm. What specific is in the middle of the forearm that you could center to? Nothing, right? It's just the middle of the forearm. Humerus. What's in the middle of the humerus that you could palpate and center to? Nothing, right? So sometimes it's going to be very specific, but the short answer is middle of the anatomy. Now define the middle of the anatomy. Okay? Don't overcomplicate it. Just look at your hand and say, what's in the middle of my hand? You know? So with that in mind, we do have to identify all these bones and the joint spaces as well. So you have 14 phalanges, you have 5 metacarpals, and you've got 8 carpal bones. So we're going to count those 1 to 5 lateral to medial. And our projection on our hand, we're going to do a PA projection of the hand, which means we're going to put the patient's palm down. So you're going to have a tendency to look at your hand on the test and you're going to say, okay, so what's lateral, right? But we're talking about anatomical position, right? So even though we're going to shoot PA of the hand, the thumb is still lateral. So we're going to go 1, 2, 3, 4, 5. Okay, from lateral to medial, your thumb being number 1, regardless of what position you put it in, your thumb is always lateral. Okay, so if you're in a hospital working with a doctor that's very specific on his marker placement, we used to have one down in Jacksonville, is very, very specific on his marker placement, or you're working with a tech that's very specific on marker placement, and they say, put your marker on the lateral side. You're doing a hand, what does that mean? Put it on the thumb side, right? So thumb is always lateral, okay? So 1, 2, 3, 4, 5. So then we've got to identify each individual bone. So we talked about this. The carpal bones are the bones of the wrist. The metacarpals are the bones of the palm of the hand. And then all of these are what we call phalanges. A phalange specifically is a finger, but each one of these things is what we refer to as a phalanx. Okay? So in the carpals, when we're naming the carpals, and there's a mnemonic somewhere on the carpal bones to help you to memorize. I don't know. I know it's in here, but in the book I'm not real sure. So, you know, if you need to take a picture of this whenever it comes up, just so you have ready access to it, you can. So proximal row, we've got the scaphoid, and the scaphoid is the proximal lateral most. Again, this is the thumb, so that's a lateral most bone. So we've got the scaphoid, the lunate, the tricatrum, and the pisiform. So those are the 4 bones. Even though they kind of go distally, they're still the proximal row. So the scaphoid is the most commonly fractured bone of the wrist. The most common fracture of the wrist, though, remember, is going, and this is a test question, so you want to, you know, take note of this. Most common fracture of the wrist is actually a fracture of the radius and the ulna, okay? But the most commonly fractured wrist bone is the scaphoid. So that's proximal row. And then the distal row, we've got the trapezium, the trapezoid, the caphitate, and the hamate. And the hamate is the one with the hamulus on it, okay? So proximal row, this is your mnemonic, so I'll leave that up for a second so that you can kind of see what that says. We had a totally different one that I'm not going to recite when I was in school because the world has gotten sensitive. So anyway, that's that. So you can freeze frame on that on YouTube if you want to. So, so our joints. we have a few things. So we've got interphalangeal joints. Those are joint spaces in between the individual phalanxes. Then we've got our metacarpals, form the palm of the hand, right? So we've got at the point of what we refer to as really our knuckles, we've got our metacarpophalangeal joint, and then we've got carpometacarpal joints, right? So then we've got to identify those as well, okay? So again, our thumb is our first digit. Our first digit, the joint space between the first hand bone, your thumb, and the thumb phalanx would be what we refer to as a metacarpal phalangeal joint. That's not enough just to say that's a metacarpal phalangeal joint. Which one is it?
First.
So first, right. So in the thumb, we only have two phalanx. We've got a proximal and a distal, so we would only have one interphalangeal joint. But in all the other fingers, we're going to get even more specific. So if a patient came in, they had a laceration is just a cut, to their, right across this knuckle right here. How we would identify that is 1, 2, 3, third. You got three individual phalanx, so we've got proximal, intermediate, and distal. So that would be our distal interphalangeal joint. Okay, so if it was right across here, that would be our more specific third proximal interphalangeal joint. Okay, so remember your numbering always goes from thumb 1, 2, 3, 4, 5, and then remember, proximal, distal, or if it's damaged directly to the finger itself or to the phalanx itself, that would be, laceration to the third proximal phalanx. Okay. So something about the thumb while I'm on it. The thumb is the only one of your digits that the metacarpal moves with the phalanx. We've got opposable thumbs, so where all of these bones, you just kind of got a hinge right there with the first digit. The entire metacarpal can move. So we've got this whole movement right here. So you tuck your thumb under, and your metacarpal actually moves with it. So you're going to have a tendency to look at that and say, well, that's my proximal. No, this is a metacarpal. That's your phalange. So you only have two sections to your phalange. Okay, this is actually your metacarpal. Thumb, we're going to have to do some specific positions. So we ran through all that. All right, some general guidelines. Patient preparation, again, simplify all this. Don't read through all this. You just want the artifacts off the patient. Make sure the patient is the right patient. Make sure that the exam fits the patient. If there's any question, go ask. There may be legitimate reasons why a patient comes in with a laceration or some sort of trauma to the left hand. You're doing a right hand. There may be legitimate reasons for that. It may be that it was entered incorrectly. So, if you shoot a right hand because that's what the order called for, and they just entered it wrong, you're going to have to go get the patient and bring them back and shoot the other one as well. So don't be afraid to ask questions. Some of your ER docs will be very approachable, some not so much, but it's your job not to please the radiologist first, but take care of your patient, right? Or please the ER doctor even, as take care of the patient, your patient advocate first. So make sure you pay attention to the position. Positions are going to be very specific. Make sure that you understand the difference between position and projection. Projection is path of the beam, position is body position. So we shoot a hand, we're going to, like your eyes are the central ray, we're going to put the hand down prone. Okay, that's a position, right? So path of the beam is path of the x-ray beam, and that would be a PA projection. Okay, so you're going to have questions that are going to see if you're paying attention. Okay, so let's say, look at my thumb. So if you could identify the position my thumb is in, what would you say that is?
Oblique.
It's oblique, right? It's oblique. It's not, you know, it's oblique means somewhere in between, you know, in this case, prone and lateral, prone and spine. It's not anything is turned, right? So it's oblique. So you're gonna have questions that say, okay, with a hand pronated, what position is the thumb in? And one of the answers is gonna say, potentially may say PA. Is that a right answer? No, it's not. Because PA is a projection. It's oblique, right? So, you know, make sure that you pay close attention to the wording of the question. What position is the hand in? Prone, supine, oblique, and, you know, what is projection? So SID, unless I specifically tell you a different SID for a specific projection, assume that everything's gonna be at 40 inches. Make sure you use your marker, radiation protection, primarily as your collimation, and then patient instructions, just be still in most cases. Once we get into the shoulder, you may have a patient, you know, hold their breath away. Any kind of artifacts that can come off of the patient, take them off of the patient. Rings, bracelets, things like that. If, you know, if it's stuck, you're not gonna pull on it. Just ask the patient to take it off, and they say if it won't come off, then you're just gonna have to shoot it with the artifact in place. The one exception to that is splints. You know, if the patient's splinted, somebody put a splint on the patient, then by the book, by textbook, you should not remove that splint. Also, be very careful in removing gauze or anything that might be stopping bleeding, because sometimes even in the capillaries and the fingertips, if the patient has an arterial cut, you know, even the capillary, it can spray. Okay, so with the gauze on the patient, you know, the bleeding is contained, and it might even be clotted, but you pull that off, and you know, you're going to want to make sure that you have something over the top of it, just to make sure it doesn't, you know, start spraying all over the place. And if it does, then you're just going to cover it back up. You know, don't put it on your image receptor while the patient's, you know, cover it up, stop the bleeding.
Would it also show up in the X-ray though?
In a hand, maybe. You know, the image receptors are so sensitive. But some of your gauze also has, and this is usually surgical, they'll have a thread of metal going through them, so that, okay, so it's a little bit of a rabbit trail, but when you go to surgery, in a trauma situation, and eventually you'll do this, in a trauma situation, what you'll find is that, well, in a regular situation, what they'll do is they'll count all the needles and all the sponges, all the gauze, everything, before they open the patient up. They'll have a witness, and somebody will count each and every one of those things. And then before they sew the patient up, they'll count them all again. And if the counts match, then, you know, there's nothing left in the patient. In a trauma situation, they don't have time for that. So some of the gauze has metal running through it, so that if it gets potentially left inside of a patient, you take an x-ray of it, you can see it. So some will definitely show up, some might show up. The likelihood of just regular gauze interfering with diagnosis is pretty low. So if it starts spraying, cover it back up, take the x-ray. So I've never worked in a hospital where we had a designated place to put, you know, patient's personal stuff, so just hand it back to the patient. Ambulatory patients, when I was in clinical practice, you know, if the patient didn't need to get on the table, I wouldn't put them on the table. As a matter of fact, if it was an ER patient, I'm probably more prone to take the portable to them than to bring them over to the department. If they didn't need to be on the table, didn't need to stand up, then, you know, fundamentally there's no difference between taking a hand x-ray on a stretcher in the ER room and putting the patient on the table in the x-ray room. You know, so move the patient as little as possible. Non-ambulatory patients, kind of the same thing, but if you have somebody who needs to come over to the department, you know, consider their situation. You know, consider their age. If if they got compression fractures and a big bowed back, you might not want to put them on an x-ray table because it's going to be very uncomfortable for them. So consider those patients as well. You're going to see a lot, your positioning in the textbook is ideal patients. If they were ideal patients, they wouldn't be in the ER. So collimation is very important. Make sure that you get your collimation. All right, so our essential projections for our individual digits are going to be PA, which means your hand is going to be prone, lateral, and a PA oblique. So the oblique, the reason the oblique is not specific, and this applies to the lateral as well, is because it depends on which digit we're looking at, okay? So individual fingers, what we're going to do is make sure that you get it in a prone position and separate the fingers. The reason for that is because if the patient doesn't separate their fingers, then the soft tissue can overlap between one and another. So separate the fingers in as much as you can. So if you're shooting individual digits and you need to see the distal end of the metacarpal and the distal end of that distal phalanx, what's in the middle of that? I'm shooting this digit, which is the second, right? So what's pretty much dead square in between here and there?
The VIP?
Yeah, proximal interphalangeal joint.
Okay.
And you can shorten that to PIP, proximal interphalangeal joint, PIP joint. Okay, and you'll see that on the test as well. So it's shortened to PIP joint. Okay. So that's your PA. So individual fingers, when we get to toes, most of your hospitals are going to want you to shoot all of the toes, but individual fingers, most of your hospitals will order a specific finger, okay? If they order all fingers, then that's fine, but a lot of times you'll be doing individual fingers. So we've got PA projection. Central ray is going to be the proximal interphalangeal joint, 1/2 inch of collimation past the skin. Make sure you include the distal portion of the whatever phalange or the metacarpal that corresponds to the phalange that you're shooting. Okay, so that's PA projection. So we've talked about magnification. How do we minimize magnification?
Put the part closest they are.
Put the part closest to the image receptor. So all these are going to be shot at 40 inches. You're not going to shoot any fingers at 72 inches. They're all going to be at 40 inches. And a couple of things about that is positioning of the patient. You can put a patient, if you get them, if they're not what we refer to as a walkie-talkie patient, you put them on a stool. You put them on a stool, and you roll them up to the end of the table. No, it doesn't.
It's going. It's going.
Is it going?
Yeah.
It's very slowly, but yeah.
There we go. There we go. All right. So you roll them up to the table. Here's an x-ray table. And you're doing a hand. What you're going to find out in physics here in a few weeks when we really start talking about the equipment is the tabletop is carbon fiber. And carbon fiber absorbs like no x-rays. All right, so you roll them up to the table and you scoot them right up under it. And you see you want you to put your hand on this image receptor, this thing on this plate. Put your hand on the plate, right? So you're gonna make an exposure, and also the image receptor, it's got some circuitry in the backside of it, but for the most part, it's going to be maybe carbon fiber, some sort of glass, kind of like your cell phone. X-rays go through it pretty easy. So you're shooting into something, into the patient, who's going to absorb some of the X-rays, but a lot of them are going to transmit. Into an image receptor, it's going to absorb some of the X-rays, and some are going to transmit. Into a carbon fiber tabletop, that's going to absorb like no X-rays. Do you see a problem with how I'm setting my patient up? What's the problem?
Their legs.
They're said it. Somebody, I could have swore I heard somebody say they're junk. Yeah, they're junk. All right. It's like, move them. You know, extend the arm a little bit. All right? Don't shoot straight into their crotch. All right. So scoot them back a little bit. Do you necessarily need to put an apron on them? Maybe not. But you can get them out of the way and you can collimate down. The patient's not going to receive any gonadal dose from this distance, right? So keep that in mind as well as radiation protection as well. So back to the distance thing. So lateral and the oblique. So in both of those cases, lateral is going to be 90 degrees from your PA. And the purpose for the lateral is to show displacement. So let's say we've got this thing going on. Let's say this is not a dry erase marker, but it's a bone that's broken. Okay. How's it look right there?
Straight, perfect.
Straight. Didn't show quite as well as what I'd hoped.
A little crooked.
A little crooked, right. So what we're trying to accomplish with the PA and lateral is we're putting two things 90 degrees from each other so we can see not just a fracture. Let's say that line through there represents a fracture. Okay, well, it's broken, but is it displaced? We could try to exaggerate that. We won't exaggerate well, but by getting the two views 90 degrees from each other, we can see that it's broken, but we can also see where the fragments are, right? Is it displaced? Is it non-displaced? They need a splint. They need to mash around on it a little bit, try to get it better lined up. What do we need to do, right? So, purpose for lateral, but sometimes when we get into the hand, the oblique actually gives us a better view of the lateral, or better view of the displacement than what the lateral does. But the lateral and the oblique are going to be dependent on which digit we're looking at. Okay, so let's forget all about the thumb for a minute. So if I've got a problem with my second digit, a potential fracture on one of them, if I turn it around this way, what kind of problem do I have? Distance. I have increased distance. What do you get with the increase in distance? Magnification, loss of sharpness recorded detail, right? So remember your lateral versus medial. What side is this? It's the lateral side. So should I put my medial side down for my second digit, or should I maybe put the lateral side down? Right. So lateral side down for digits 2 and 3, medial side down for digits 4 and 5.
So would you say that's medial-lateral rotation?
That, okay, yeah. So that would be more of a projection. Okay, so that would be if I put it down like that, that would be a medial lateral projection.
Okay.
We're not going to get that specific on the test.
Okay.
Okay. We're going to get specific in the positioning, but as far as projection, no. Okay, so the same thing follows for obliques. Also, to simplify everything, until we get to a point where we get up into the shoulder, every oblique that you're going to shoot until we get to the shoulder, and I'll be specific when we get there, 45 degrees. That's it, 45 degrees. Oblique of the hand, 45 degrees. Oblique of the finger, oblique of the elbow, okay. All right, so until I tell you otherwise, every oblique is 45 degrees. So that's like 4 different things that if you put them in little boxes, you don't have to, think about those anymore, okay? So the obliques are the same way. They're going to be 45 degrees, and the degree of obliquity is going to be determined, or not the degree of obliquity, but the direction of obliquity is going to be determined by the individual digit, right? So if, again, you're looking at 4 or 5, you're going to oblique towards the medial side. Destiny was asking about can you bring that question back up?
Yeah.
Because it really had two answers to it. Now, I want y'all to understand that any registry test prep or software, they're going to have errors in them, right?
You can read it.
Or you can read it. You don't want to read it. There's a reason I don't read in front of class. I got some dyslexia going on, you know, and when I get to something that I have to read to you, sometimes it's a beating. All right, so it says, which hand position is used to demonstrate it? Uh-oh, your battery's about to go dead. To demonstrate the anatomy of interest when performing a lateral projection of the second digit. So we just did that. So pronated and flat on the image receptor? No. Rotated medially with the digit resting on the image receptor. Okay, well, you're here, and from your body position, you're rotating internally, which would seem to be medially, right? And I think, was that the answer?
No, the answer was the internally.
Yeah, okay, okay. So I think internally rotated is a better answer after thinking about it for a minute. Arched with the fingers resting on a sponge? No, and I'll tell you why that here in a minute. Or rotated internally with the digit extended. I think that the answer, the best answer is rotated internally with the digit extended. I think that that's better than rotated medially, because really, even though you're rotating towards, you know, your midline is still towards the lateral side. So I think that's your better answer. What's that?
Because of the thumb being lateral?
Yeah. Okay, so any questions on individual fingers? PA? On all three of these, the central ray location is the same, collimation is the same, proximal interphalangeal joint, PA, fingers extended, lateral, finger extended, proximal interphalangeal joint, oblique 45 degrees.
How are you setting it up to do oblique?
Well, it follows the same rule as the lateral. So if you're doing oblique, you know, if you're doing, say the second digit, you'd internally rotate 45 degrees. So that would be for digits 2 and 3, and 4 and 5 would be external rotation. One thing though, you know, you're gonna have a tendency to think, well, I gotta keep my OID low, right? And you do, that's why you're doing them, you know, different obliques and different laterals. What you need to do is resist the urge to rotate up. Let's say, to keep it nice, let's say we're doing my ring finger, right? So I'm doing 4th digit. And what you're gonna have a tendency to wanna do is, well, I gotta keep my OID low, so you're gonna do that, right? You don't wanna do that. And again, back to the marker, let's say now that this doesn't represent fracture, but this represents our joint space. Okay, you can see the joint space, right? How about now?
Not as much.
Not as much, right. So you want to keep the anatomy parallel to the image receptor and the central ray perpendicular to the image receptor so that you don't close the joint space up.
So just prioritize that over it, but
Yeah.
still try for the.
Right, yeah. Keep it as parallel as possible, but keep your OID as low as possible. Yeah. Yeah. So the thumb creates different problems. It creates a lot of problems. So the key points on the thumb you want to remember is that the thumb is the only digit that we want to include not just the thumb itself, the thumb proper, but we got to include the entire metacarpal. It's also the only thumb that with the hand pronated, it's an oblique, all right? So your positioning for the thumb, for an oblique of the thumb, is to do what with the hand? You're there, right? The easiest thing to do, just put it down, you're there. But what you need to do is you need to change your central ray location. Instead of being at the metacarpal phalangeal, well, you need to change your collimation. So you're gonna focus on the metacarpal phalangeal joint instead of the interphalangeal joint, and you want to open up your collimation to include the entire metacarpal. Okay. So you got fractures in the thumb. They're specific to the thumb. A Bennett's fracture is what we refer to as ski pole injury. If you've ever been skiing and you had a pretty nasty wipeout and you had the straps around your wrist, you kind of know that it'll wrench your thumb and it hurts, right? So extreme case of that, in an extreme case of that, what you get is a fracture of the proximal first metacarpal. That's ski pole injury or Bennett's fracture. Okay, so we're trying to catch that. So PA or prone position for the hand gives us an oblique of the thumb, right? So a lateral of the thumb, what we're going to do is we're going to elevate the fingers until the thumb is in a lateral position. You can bend the fingers up if you wanted to. You can bend the fingers up to kind of give some degree of stability. You want to make sure that you don't have the thumb too close to the hand or you get too much soft tissue overlap. It kind of interferes with the visualization. So extend the thumb in as much as the patient can. Bend the fingers up, rotate the thumb into a lateral, also easy. But make sure you include the proximal end of the metacarpal. The AP is really the hardest part. So that's the other thing that's specific to the thumb. Is we don't do PA. Everything else, we did PA, and thumb we're going to do AP. If you did PA, look how much of an increase in the OID you would have to truly get it into a position where you get a PA. Okay? So instead, what you're going to do is you're going to have the patient rotate their arm until your thumb is in a more of a thumb specific, I don't want to say supine position, because that would imply the hand, but the thumb would be more supinated. Okay, so your hand is going to be a little bit oblique. How you get the patient into this position doesn't really matter. You just got to get them in that position. So, you know, if you had the image receptor and the patient could do it, just have them, you know, turn their arm like that. Right? One thing that you want to guard against is having the hand too vertical, because then you not only get soft tissue overlap over the proximal metacarpal, but you also get some bony overlap as well. The other way is to rotate the arm around like that. And that's probably more common to get the hand in the way. All right? So make sure you get the hand out of the way. The thumb on the posterior surface. Okay? So what are the key points on the thumb that are different than anything else? Only one that we shoot AP. The only one that we include the entire metacarpal. Right. All right. So there's your Bennett fracture. Also, this is not the same patient. We've got open growth plates in this patient. So things that we can see, arthritis. So, you know, you got a couple of different types of arthritis. Notice this patient has no joint spaces left. That's just osteoarthritis. That's just wear and tear. If you don't feel any now, eventually you will. There's sesamoid bone. All right. So sesamoid bone in the hand, that's the only place that normally in you know, most anatomy you're going to see it. Rheumatoid arthritis really distorts the joints, and the bones take on an appearance of osteoporosis. So osteoporosis is a condition where you get demineralization of the bones. Bones get much darker in appearance. So rheumatoid arthritis, you can usually see the deformity before you make the exposure. If you've got a grandparent or something and their fingers are really kind of bent up, that's probably what you're looking at. Okay, any questions on fingers? All right, now I'm 40. Okay, so hand. The hand is really not unlike the fingers, you know, prone position. The only difference here is central ray location collimation. In this case, again, your central ray location is going to be to the third metacarpal phalangeal joint. A couple of things about the hand that may seem, once you get a patient forehand, that may seem a little bit counterintuitive, is that, you know, in positioning of the hand, it says, okay, I need my central ray to the third metacarpal phalangeal joint, and I need my collimated field to be no more than a ½ inch past the anatomy, right? So collimated field is about here. What do I have a problem with? Clipping the thumb, right? So this is a little bit of you've got to know third metacarpophalangeal joint for the test and for the registry. But in a practical sense, what you may have to do is you may have to center a little bit medial and open your collimators up a little bit to make sure that you don't clip the tip of the thumb. The other mistake that's probably the most common mistake that when I was in, clinical instructors that I would see students do on a hand is that they would collimate the tip of the thumb off. Okay, don't do that. It's a repeat. You're not going to get your check off. Okay, and the other mistake is they would take the thumb and they bunch it way up like that, and you're going to get again superimposition of at least soft tissue, if not bones. So you can extend it a little bit, right? If you extend it way out like that, just make sure you open your collimation enough to see it. Okay. So PA of the hand, we have two different potential laterals and obliques, really. And what you'll see is that sometimes, we'll take these in a sequence. We'll do the PA of the hand, and technologists will tell the patient, I want you to make OK sign. And make sure that if you tell a patient that they don't go, some people like to do OK sign like that, right? Mash their fingers together. They just need a touch. So make OK sign. And sometimes what we'll do is PA, make your exposure, do the OK sign, and it rolls the hand up into pretty close to a 45-degree angle. Okay, so now the most common mistake that I saw was that people would clip the pinky finger off. Okay, so make sure that you get a good look at your anatomy and make sure it's all in the light field before you make your exposure. So we got an oblique, but there's an inherent problem with this oblique. And if your radiologists are okay with it and it's hospital protocol, that's fine to do it like this. But if you use the fingers as props for the oblique, what are you not going to see well?
The joint spaces.
Joint spaces, exactly. So your fingers, instead of being like this, are like that. So joint spaces are going to be closed. Okay? So if you use the fingers as props for an oblique of the hand, you're not going to see the joint spaces. So if you're interested in seeing the joint spaces, what do you need to not do? Yeah, what you need to do instead of using the fingers as props is extend the fingers. Okay? So fingers parallel to the image receptor puts the central ray parallel to the joint space. Right? And this bears some explanation because some of y'all are going to miss this on a test sooner or later. All right? So central ray perpendicular to the anatomy is not the same as parallel to the joint space. If it's parallel to the joint space, you can see through the joint space. Does that make sense? If it's perpendicular to the joint space, it's like that. Okay? So your central ray is going to be perpendicular to the third metacarpophalangeal joint. It's going to put it parallel to the joint space that corresponds to that. Does that make sense? Perpendicular to the anatomy, parallel to the joint space. Now, the joint space also has to be perpendicular to the image receptor. Y'all are going to struggle with perpendicular and parallel. Mm-hmm. Okay? You just are. Every time you think you got it down, it'll throw you a curve. Okay, so same thing applies to the lateral. So we did the PA, we did the oblique, and regardless of whether we did oblique with the fingers parallel to the image receptor or use them as props, doesn't really matter. What we're going to do now is we're going to rotate up to a lateral. Now we've got two different laterals as well. One is what we refer to as a fan lateral. It's a fan lateral because your fingers are fanned out. Okay, so you got a fan lateral, and that's good for demonstrating individual fractures in individual fingers. Okay, but if, like my oldest son, he's a welder fabricator, and that boy hates his hands. He almost amputated a thumb and then tried to take a couple of fingers off in a different incident. He's got metal in his hands. Okay, somewhere in his hand, he's got some metal. So the problem with a fan lateral for a hand is that if you're looking for a foreign body, look at how much soft tissue I've overlapped here as opposed to that, okay? So I'll go back in reverse order with it, and look what happens to the soft tissue. Harder to identify exactly where the soft tissue is with the hand all wadded up like that. So if you're looking for fractures in individual digits, what are you gonna do? Fan. If you're looking for foreign body in the palm of the hand, extension, fingers extended, okay? Some of your hospitals, that's routine protocol for all hands, okay? So a couple of things about this is you're gonna have a tendency to tell the patient, I want you to put your hand up there like a karate chopping something, right? And this is exactly what they're gonna do, okay? So how much do you have superimposed here? You've got a lot, and if you do this, you got more, right? So can you move the thumb even if you're doing a hand, lateral hand in extension? The answer is yeah, absolutely can. All right, so get the thumb out of the way, regardless of which way you're going with it. Soft tissue damage, you know, foreign body, this is your go-to move. If you're looking for fractures in individual digits, then you're gonna do the fan lateral. Okay? I'm gonna get in trouble. Okay, so that's hand. Let's talk about a couple of projections of the wrist, and then we're gonna be done. And you can go to here and ask what I did with all my time this morning. Bounced on a chair. All right, so PA of the wrist. We're going to do a PA of the wrist. A couple of things about a PA of the wrist. Nope. This one. All right, so the wrist bones, what you'll read in, you know, test questions, textbook, whatever, the wrist bones are conical in shape. What does conical sound like? Cone. They're cone shaped, okay? And a cone, you know, is just two-dimensionally and very exaggeratedly, the cone looks like that. And they're cone shaped, and the narrow portion is anterior. Okay, so the narrow portion is most anterior. So we shoot our wrist bones in a PA projection. Now, let's take a little bit of a divergence and explain how the X-ray beam comes out of the X-ray tube. So it comes from a very small area, maybe a little bit smaller than the tip of this dry erase marker. It's a very small area, and it has to spread out to cover your entire image receptor, and that's what we refer to as divergence. It's divergence of the central ray. Now, let's say we've got two pieces of anatomy side by side. And we got our X-ray beam coming from this small source. Which one is probably going to show more magnification and more loss of sharpness or recorded detail? Well, we even come from the same spot. Where the fat part is away from the image receptor is down here. Fat part is away from the image receptor or closer to the image receptor. Away? Yeah, away. So our wrist bones are more narrow on the anterior portion than what they are in the posterior portion, but we put the posterior portion further away from the image receptor. You're going to run into a question on a test, maybe all the way through the registry, that says that if you're looking for the carpal interspaces on a wrist X-ray, then your better projection will be to shoot it. It's going to give you PA, AP, oblique, lateral, and your answer there is AP. Okay, we shoot PA, but the answer to that specific question, you'll see it sooner or later, is to shoot AP. Okay, if you're looking for the carpal interspaces, AP is your projection, but we shoot PA. All right, so a few other things about our PA of the wrist is this, okay? If you take your hand and you put it on your desktop and you put your fingers straight out, what do you notice? A space, right. If you bend your fingers up, what happens to that space? It goes away, right? So in your wrist, what you're going to do, all the stuff we talked about before, your central ray location is going to be the middle of the anatomy. But what you're going to do is you're going to take your patient's hand, you're going to put it, flat on the image receptor and bend the fingers up, not until they clench, because what happens when you clench is that they, it draws it back up, right? So bend the patient's fingers up until the anterior portion of the wrist is in contact with the image receptor. Reduces the OID, increases sharpness of recorded detail. Okay? All right. There was something else I was going to mention as well. I forgot what it was. Let me see if I get a reminder here. Oh, yeah. This is it. This is weird. Okay. So put your hand down just right on your desk, and you feel that knot on the back of your wrist. Okay, that's radial styloid process. If you read through the evaluation criteria in the book, it's going to say that that's ulnar styloid process. It's going to say that the ulnar styloid process needs to be in profile. What's a profile? It's a picture from the side, right? So if I shoot my wrist with my hand down like this, the ulnar styloid process is sticking straight up. Are you going to see it in profile? No. Now keep a hand on that thing and raise it up to shoulder level and tell me what you feel. Yeah, it's weird, isn't it? It's kind of funky. It rotates out so that you get it in profile. So what your book doesn't tell you is that, can you feel it? Yeah. Now you're going to be playing with that all day long. Okay. How many of y'all, after we went through chest x-ray, we talked about breathing instructions, you couldn't breathe right the rest of the day? Yeah, kind of the same thing. You're going to be playing with that all day. All right, so what your book doesn't tell you is that you need to put the wrist, the elbow, and the shoulder all in the same plane in order to accomplish that. Okay, elevate all that down, which may mean that you have to either get one of those big square sponges and put it under the image receptor, or you may have to have the patient kind of, get down, lower their shoulder in order to put everything on the same plane. If it'll go that high. Yeah, but and you may have to put take the stool out from under the patient and get them to kneel down in order to accomplish all that. Okay, so PA of the wrist, you've got everything in the same plane to put the ulnar styloid process in profile. Bend the fingers to put the anterior portion in contact with the image receptor. That's your PA of the wrist. Your oblique is going to be 45 degrees. Very good. And your lateral, on your lateral, if you read the evaluation criteria on your lateral, you need to have the radial styloid process and the ulnar styloid process superimposed. Okay? Now, holding on to both of those, what do you feel? If you've got a finger on both of those at the same time,
They're off.
they're off, right. So if your hand is straight up and down, and you can use the palm of the hand as a good guide for a lateral of the hand, doesn't mean you're going to get a good lateral of the wrist. Okay? So what the book also doesn't tell you, and this is a positioning just trick that you might use in clinicals, is to supinate the hand just a little bit. If you externally rotate, supinate the hand just maybe 5 degrees, then the radial styloid is going to go that way, the ulnar styloid is going to go that way, and they're going to perfectly superimpose. And I'm talking about a little bit. We're going from here to there. It gives you a better wrist. Okay? So PA, 45-degree oblique, that's external rotation. One thing about the oblique, what it will show you better than the other two projections is a potential fracture of the scaphoid. So where are most of your wrist fractures?
The radius ulna.
Radius and ulna. Most common Wrist bone that's fractured? Scaphoid. The problem with scaphoid is that it's at an angle like that, okay? So PA projection is at an angle, all right? So the oblique, what happens with the oblique is it takes it and puts it more parallel to the image receptor. You can see it a little bit better. Okay, so the takeaways, you know, you got your PA and your lateral 90 degrees from each other. The takeaway from the oblique is that it shows the carpal bones on the lateral side of the wrist, even though they're elevated, you know, lateral side, even though they're elevated, it shows the bones on the lateral side of the wrist, especially the scaphoid fractures. Okay? And we are out of time. Any questions? All right, then we'll pick up there on Monday.